This episode is brought to you by podiatrygrowth.com/podpatrol.
So for the Pod Patrol listeners, what should they do to take advantage of the assistance that you can provide?
I worked with Jeff here to create a 5-day email course talking about 5 different systems that are going to help you drill down on what's important as far as gaining new patients. And if people enjoy that, I always have the option of 30-minute free strategy session where we kind of go over what people's current challenges are.
So a 5-email introductory course. That sounds expensive. What are we paying for that? $1,000, $10,000? What are people going to expect to pay for that introductory course for them?
Yeah, this is a free gift to my colleagues. Just gives you an opportunity to do a bit of a self-assessment.
If anyone's interested in more information, they can go to podiatrygrowth.com/podpatrol.
Podiatrygrowth.com. Every step matters. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters. Feet hit the ground, we rise, we climb. Ain't stopping now, it's our time to shine. Turn it up loud. Pod Patrol. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters.
All right, welcome back to Paw Patrol with your host, Dr. Jeff Dikis. Tonight, I'm joined by Dr. Corine Creech. Thanks for joining me.
Yeah, thanks so much for having me.
Absolutely. So you and I have crossed paths a few times, and we have gotten to know each other a little bit. But for anyone who doesn't know who you are, why don't you go ahead and introduce yourself real quick?
Sure thing. So I'm Corine Creech. I am based in the Northern Virginia area. I work for the Inova Medical Group. I am part of the Inova Fairfax Medical Residency Podiatric Training Committee. I'm section chief at the Fairfax campus as well and lead our research efforts. But I'm originally from Columbia, South Carolina, proud graduate of the university there, and then did all of my podiatric training at Temple, the podiatric medical school there, and then stayed on for the residency program at Temple University Hospital.
So you and I were talking a little bit ago. It used to be a 4-year program when you were there. So you kind of did a victory lap. You did the 3 and then you went around one more time. So what do you think that extra 4th year, I know it's not that way anymore, like you said, but what do you think that extra year kind of provided for you?
You know, I think initially it was really built as a trauma and peds heavy program. And so the idea was like your chief year was really this sort of fellowship year. And that was really before this big push that we've seen recently by the college to sort of encourage fellowship and extend education. I rotated when I was at Temple up at Sinai in Baltimore, and there was a guy by the name of John Herzenberg who always said, you know, I just feel like the one disadvantage that you guys have versus the orthopedic residents that come through here is just the time you have in a hospital, the time you have interacting and seeing things. And I think that is very, very true. There's such a maturation that occurs over that 3-year period, let alone that 4th year period. And, you know, so yeah, I'm a proud OG graduate. So I'll put an asterisk there for that.
For sure. I mean, I think that's interesting because we have shifted towards more and more people doing fellowships for better or for worse. I mean, I think you could skew it both ways. Some people would benefit, some people maybe not necessary. But getting that 4th year, I mean, I don't think anyone's going to say that an additional year of training or any extra year of training, as long as it's good quality, is a bad thing. So I think we're a little different, though, from the orthopedic colleagues in that we become hyper specialized and we're focusing on our craft a little sooner. But I completely agree with what he said, which is more training is going to be beneficial for you in the long run.
Sure.
So you played soccer at South Carolina.
I did.
Grew up playing soccer, obviously, and must have been pretty good.
Yeah, I started a little later. I mean, now I look at the way that kids start so early and the training that they have and just these incredible athletes that come through our office. And I'm like, God, I'm so glad I played when I did. Because, I mean, you know, you see these like 6 foot tall 12-year-olds and you're going, my goodness, I would have loved to have had your training at that point. But yeah, I figured out I had a knack for it. My parents were super supportive and just kind of found myself in the right place at the right time, and huge Carolina fan. I wanted to play for Carolina before they even had a team. So it was really a dream come true for me.
Yeah, we had Bob Anderson on our Gatekeepers Journal Club, and we were talking a lot about sports injuries and how people are becoming so hyper-focused on sports at younger and younger ages, which
Hmm.
is good for the athlete. But from a medical slash health standpoint, we're seeing earlier and earlier onset of bone stress injuries, Tommy John surgery in high school pitchers, all these injuries that are accumulating before they even get to college, which is crazy to think about. So there are pros and cons. Like you said, it's different now than when you
Hmm.
kind of went through. But there are pros and cons to that, because if you end up getting injured at a young age, then that wasn't necessarily necessary, and that derails your entire career. Well, you're going to wish that maybe you didn't get so deep into it as early as you did. I don't know.
Sure. Yeah, I don't disagree.
Yeah. So you work with the residents there.
Hmm.
And would you like to
Yeah.
tell anybody, because I get a lot of students listening to the program, give a couple little spiel about the residency and tell people. I mean, obviously, Inova is one of the top residencies in the country. Don't need to sell it, but give a little spiel about what the residency is all about there.
Yeah, so we're a very heavily surgical based program. We take 4 residents a year for our 3-year program, and they are based throughout our Inova campuses. Inova is, and I do work for them, grain of salt and a little Kool-Aid, but it's an incredible health system and continuously one of the top in the area, which is a lot to be said. The DMV is really heavy with healthcare, so they get a vast variety of training from not only podiatrists, but also orthopedic foot and ankle. I think that most of them have their case numbers by the time they're, second year. So heavy recon, total ankles, MIS, all that good stuff. So yeah, we're very proud of it and very grateful to be a part of it.
Absolutely. So DMV, where I come from, is Department of Motor Vehicles. So for anyone who doesn't know what that is, explain what that means.
That's DC, Maryland, and Virginia. So a lot of people in the area say the DMV because it all kind of runs together. And a lot of people will say like, "Oh yeah, I live in DC," but they live in like Alexandria. So, it's very similar to like Philly, Delaware, and New Jersey. It's like this tri-state area. But it could
Sure.
also mean the DMV for sure, because we have one of those too.
Sure. So you're at the DMV in the DMV. That's going
In
to
the
get super
DMV.
confusing.
It can be, yeah.
So do you work out of multiple hospitals or one hospital? How does that work? Because it's a health
Yeah,
system.
I'm anywhere they will let me go. So because I work for the health system, I do stay within, but I go to basically every hospital, kind of within a convenient area to my patients, and a couple surgery centers as well.
Sure. So what are your tasks as a research director? What kind of things do you do with the residents, and how does that title actually, what do you actually do on a daily basis? Not maybe daily, but what do you do with that title?
Yeah, so when I first got started, we did not have much coming out, and there was a lot of transition internally for Inova to have this more organized IRB and those kinds of things. And IRBs are great, but they definitely are difficult to sort of figure out and maneuver. And so when I came over and joined the health system from private practice, it was a little bit easier because it's just easier to work internally from the health system. I work with our major research coordinator, a guy by the name of RJ Elbin. He does a lot of concussion stuff, so the world of foot and ankle is very new to him. So I think he's always trying to figure out what we're talking about, but he's great. And they're very supportive, but it also is a very organized and stringent process. So the first thing was just kind of getting all of that organized, figuring out how we could do this safely and appropriately and by the health system standards, and then facilitating resident ideas. So when I was at Temple, Andy Meyer was there, and he was really just this great sort of like, I have an idea, and he would help you kind of figure out how to do it. And so that's really how I've sort of fashioned my role here, is to be not only an intermediary or face to the IRB, but also to sort of facilitate resident research and ideas. I do a topic driven journal club every month. So we also kind of steal a little bit of that time to sort of say, what other projects we're working on? What are the major conference deadlines that we're looking at, so that we can have a strong showing? And I think it's worked well so far.
So how do you come up with research ideas? Because number one, every time I seem to have an idea, it's already been done. Not that you
Yeah.
can't do it again or do it in a different way or do something, but or it's just hard to come up with something that's novel and unique and worth your time. So how do you, maybe you come up with an idea and then maybe you need to narrow down and try to figure out, okay, is this actually doable, and or is this worth our time? How do you kind of facilitate idea formation and then make that a reality?
Yeah, I think it's a great question, and I don't necessarily have a great answer to that. I would say I just really have found the more that you are talking about things and curious about things and around things. So radiology rounds and journal clubs and things that were going, oh, it doesn't really make a whole lot of sense to me. Like, has anybody ever looked at this or that, or how could we make that better? You know, a lot of our off service residents will say, like, oh, they're doing this in ortho. Do we do anything like this in foot and ankle or podiatry or vascular, whatever? And kind of
Sure.
just, I do think there is very little original ideas. It's all kind of ripping off something else, whether we realize it or not. But, I mean, some of it's like you're on a treadmill and you're going, I don't know, has anybody ever looked at, the rates of fusion of MIS versus whatever, so
Right.
it definitely, I think, is just I'll do it all the time too, is, send an idea to whoever the research chief is and say, look into this. Tell me if this is something we need to do.
Yeah. And the flip side is true too. Sometimes I do something and then I think everyone else does it that way. And then
Sure.
later I realize, oh, you guys don't all do this specific thing. Like, oh, I should have written that up. And so
Mhm.
sometimes you don't know that something could be a good idea until you kind of sit down and make it the forefront of what you're actually thinking about. So to have someone like you who's at the forefront of trying to come up with those ideas is going to be beneficial for the residency.
Yeah.
Speaking of the
It's good for me too.
residents, good. Speaking of the
Yeah.
residents and research, you are a reviewer for JFAS and JATMA.
Mhm.
So
Yep.
I've done some reviewing as well, so I know the answer. But anyone listening, tell them what that means to be a journal, not journal club, but a journal reviewer, and getting those articles and how you evaluate and how you figure out whether they're good or bad or maybe need some tweaks.
Yeah, so essentially, you are asked to join. I'm sure you can also ask to join, but you'll be sort of assigned to a section. Initially, when I first started, I was doing like a lot of diabetic review, and now I've done some recon and moved on to some other things. But it really, you get like an email every so often, and it says, "Hey, are you interested in reviewing? And if so, you have this amount of time." They give you access to all sorts of journals and resources so that you can do some fact checking and back reading, and then you're really getting that manuscript sometimes in its roughest of forms, and particularly when they're foreign language articles kind of coming over, you're evaluating everything from like the word count, which when I first started, that was like, yes, I can check the word count and I am going to comment on it every single time. But you're doing that to like picture quality and those kinds of things. And most
Yeah.
journals will give you like points that you're really assessing on. And then you can get into the nitty gritty of the topic. Is it an original idea? Is it something people are going to be interested in? And then ultimately, does it need further review? And most of the time, it needs something.
The foreign ones are tough
Yeah.
because the translation is not usually
Yeah.
fantastic. And I do not blame them, because if you translated I try to translate mine into Chinese or another language, I'm sure it would be awful. So it's a two-way
Sure.
street, but some of those need a lot of revision when they come in, not
Hmm.
because the quality is bad or the idea is bad, but because just the sentence syntax and structure is just like completely off. And you don't even know
Sure.
where to start. You're like, this is difficult. We need to kind of start over, or have
Yeah.
a native English speaker take it from the top and just put it all back together.
Yeah.
But those are tough when they come in, because you're analyzing the idea. You almost have to extract the idea from the English language and say, well, the idea is good and the pictures are good, but the sentences need some help. So those are tough, I think.
Yeah, I agree. I agree. And it's always tough. You hate to be so critical. You'd never know
Right.
if you're being like overly critical of something, but that's your job. So I'm pretty good at being critical.
I think the older you get, you start to care about people's feelings just a little bit less,
Yeah.
and you're just like, all right, here's the truth. Here, we're just gonna cut
Oh,
through all that other stuff, and here's the truth. We're
yeah.
gonna cut to
It's
it.
a blinded review for a reason,
Right.
No, I'm just
True.
kidding.
Have at it.
Yeah.
So when you work with the residents, that can be fun, rewarding. It can also be difficult because sometimes if you hand over the knife, that can be a little difficult because you went through all of your training. Now, as you get kind of further along in your career, maybe it's a little bit easier. It's easier for me to hand off the knife and say like, okay, go for it. I've done 100 of these.
Mhm.
But how do you view that as teaching the residents, and when to let them do some of it or when to let them do all of it? Or how do you integrate the resident into someone who's your pre-op patient, your surgical patient, and your post-op patient? Ultimately, you're responsible for them.
Yeah, I think it's a real conundrum because you are ultimately your first responsibility is to the patient, but you also have a huge responsibility in like raising someone, and you know the things that you still hear in your head 10 years out, and the things that you're cognizant of and conscientious of are the things that someone taught you to be. So it's a real responsibility. I think there are early procedures like debridements and those kinds of things where they can learn good sort of skills and safety and that kind of stuff.
Yeah.
But for me, it was always like, can I fix this? Like if you mess this up, can I fix this? And I think you get to a certain point of your career where you feel comfortable in the parts that are safe for them to do and give them some ownership. Because we also all know what it feels like to be standing there with no involvement in the case and how uninterested and disappointed you feel. So, I think for me it's really identifying the steps not only that they've done, but those that they've struggled with. We had like a really interesting lecture with the general surgery residency director. And it was really this like preparing for it almost like a game, like when you're at the scrub sink, kind of talking through the case. So usually we'll do that the night before of like, what's the game plan? What hardware are we using?
Mhm.
They have access to my notes. So making sure that they have taken ownership of knowing that patient. And then also for particularly challenging cases, like which parts can they expect to do so that they know kind of going in, hey, this is a total ankle. There's going to be very little of the critical portions of this that you're going to do until much later in your training
Yeah.
versus an MP fusion that they've done 40 times and you feel confident in letting them roll a little bit. I think it's also really hard to watch them struggle because you want to, it's uncomfortable to watch people that you like struggle,
Yeah.
but B, you're moving and you're watching that very expensive surgical clock and those
Mhm.
kinds of things. So it is a great but large burden for sure.
It's really hard to not say, here, give that to me. I
Mhm.
find like if they're not holding
Yeah.
their hand quite right. Now I'm working with third year students. So
Mhm.
this is like boom, way early. I don't expect them to
Yeah.
know anything, but it's really fun. They're super excited to throw this screw and make the incision. And I tell them the same thing that Dr. Burns told me when I was a resident, which is he would say, listen, there's nothing that you can do that I can't fix. And it
Yeah.
gives you this little kind of like comfort zone of like, okay, all right, if he's watching, he knows what we're doing, he knows what's going on. And like you said, can I fix this? If there's something that they do, is it going to be easily fixable or not? And I think that's where you kind of draw that distinction. If you've gained that comfortability with that resident, then you understand what they're doing.
Sure.
What do you like about teaching residents? Obviously, you elected to or join that program and be a part of that program and be one of the faculty there. So obviously you like teaching. What do you like? And then maybe what are some of the hardest things about teaching or being involved in a residency?
I love the watching the progression and seeing what adults they turn into. It is such a fun thing to watch because we'll typically see them as students, and you'll remember like the one weird thing that they say, and we've all got like our stories, like oh the one time I didn't make Dr. Meyer's patient MPO, which is a true
Right.
story. And all those things. So like kind of collecting these little memories with them is just I think it's such a neat thing to be part of someone's journey.
Hmm.
I think the hardest thing is to correct and discipline and not crush, because I think that we're all built so differently.
Sure.
I've always been like tell me I can't do it is like that's the motivation that I need, but it's very different for some people. And figuring out what motivates one person versus the other without kind of crushing their enthusiasm, I think is a really I wouldn't say it's a challenging thing, but it's something we have to be so careful of for sure.
Yeah. I agree with you that it's fun to watch the growth. And my wife deals with this teaching the 3rd and 4th year student, but it's a little bit, I don't know if disheartening is probably too aggressive of a word, but when they're new, they don't know anything. And by the time
Mhm.
they get to the end of the year, they're firing on all cylinders. They know how to work up a patient. They know how to do this, and this, and they're actually quite helpful. And then they leave. And a new
Yes.
batch of fresh faces come in who don't know anything. And you're starting back at square one. It almost
Yep.
feels like you're teaching the same thing over and over and over again. So
Yeah.
there's good and bad to it for sure.
Yeah. You
What?
get to tell the same ridiculous stories though every year, and you have like a fresh audience. So that I find that that's a helpful thing for me.
That's true. That's true. I'm sure I wear people out. So they only have to deal with me
Mhm.
for a month at a time and then they can move
And then
on.
they
They
move
still
on.
like me by the time the month is over.
Yeah. Yeah.
What is one thing you think that let me rephrase that. What is one thing you have learned over your career that you wish you knew earlier? You've been out in practice for a little while. What
Mhm.
is something that you now know that you wish you could kind of whisper in your ear back maybe 10 years ago?
I think it's, to trust the process and it will get better. I remember the first 3 years of my career were incredibly humbling. And my mom was teaching piano at the time, and she had I think he was like a cardiothoracic surgeon. And we were talking once at like one of her holiday recitals. And he's like, "How's it going?" And I said, it's a big responsibility." He goes, "Give it 5 years, 5 years, and everything will seem like just one more day." And I'm thinking to myself, I got 2 more years before I hit 5 years. Like I got 2 more years before I stop worrying about everything. But at some
You're good.
point, it becomes kind of like, I've done 100 triples, or I've done 100 whatevers, and it gets better. But then I think there's that same part of it that goes, you're going to get comfortable with it, but there's still other things that are going to make you excited to do what you do. So just trust the process. And I think also like keep pushing. I think that there's some tough things that we all go through as practitioners, that we have to kind of push through to really see some growth, and know that, tough things are going to happen. It's part of the gig and the responsibility, but getting through that and learning from that, I think it's much easier looking back at some of those experiences than it is kind of going through them.
Absolutely. You and I have crossed paths in the world of MIS, minimally invasive
Mhm.
surgery, which seems to be a growing topic or growing area of interest in our profession.
Sure.
To be able to do MIS or consider adopting MIS, you have to be open to change, because I think you and I, or people of our age, could get set in their ways and say, well, I do a Lapidus this way, or I do a first IPJ fusion this way, or I fix an ankle fracture this way. Why do I need to change? And maybe the answer is you don't, but maybe there
Mhm.
is a better way of doing something. So you and I, by nature of trying these things, have to be open to new techniques and new technology that comes down the line. Do you think that's a big part of adopting MIS in the first place? And then what made you think about trying to do some of these things in a new way compared to the way that you used to do them?
Yeah, I think it's 100% figuring out if you want to go down that path, because it is like by the time, I started pursuing it, I'd kind of hit that 5 years where I was like, yeah, just another Lapidus, no big thing. And do you really want to go from something that you've become very efficient at to like a whole different learning curve? And I think that some of that for me was driven by the desire. I just really I don't know that I was just a big believer in distal osteotomies. I don't think I was very good at them, but I just never even other people's patients that I was seeing, I was just seeing constant arthrofibrosis, and like found myself trying to convince a patient that an x-ray looked good. And would I have recommended an Austin to one of my family members? Absolutely not. And I was doing Lapidus on everything. And I still love a Lapidus. I do them minimally invasive now, but I think that, you should not find yourself in pigeonholing everybody into one surgical procedure because you're good at it. It should be the procedure that's right for them. So when I started to look at MIS, I was really looking for something different for that particular part of my practice, not really understanding that some of the smaller bunions were probably a little bit more challenging from an MIS standpoint. But again, I do a topic-driven journal club, and I selfishly made MIS and bunions a couple of different topics so that we could really delve into the literature and see like what that looked like before I kind of dove in. And then when I started, it was the ASC was in San Antonio that year.
Mm.
It was 2020. It was like March. And
Oh,
then
yeah.
like, remember? Yeah, like 3
Yeah.
weeks later, everybody's going, was that a super spreader event? It wasn't, thank God, act fast. But it was like everything kind of came to a grinding halt. And I
Yeah.
find myself in a new practice with brand new patients and this kind of new thing that I'm interested in. And so that was like February, like when I saw February, March, when I saw that stuff. And then the first lab that I went to wasn't until August. So it just kind of kept coming back to me. And I really did not think I was going to be very good at it. I wouldn't say that sort of three-dimensional relationship initially was something I felt that I was very good at. So I was a little pleasantly surprised when I went to the lab and it all really clicked for me very well. And then it just really was the trajectory of growth from that point. But yeah, the learning curve was real. And I found myself going, man, I could be done with this and I'm still throwing a wire, so that was tough for sure.
Yeah, it is. It's one that thinks that that certain MIS procedures are much easier once you know how to do it open. If
Sure.
you've done open Lapidus and you know the contours of the joint and you can picture that in your mind, it's much easier for me to make a small percutaneous incision and stick the burr in there. And I can picture in my mind exactly what I'm doing and what I'm resecting. Obviously, I'm using fluoro to assist with that. But when you do open procedures, it makes MIS a lot easier. And so I've frequently kind of wondered as we get down this road, if we don't still teach open procedures, if that will make MIS actually more difficult for people because they don't know what the inside of the joint looks like. They don't know exactly where that tendon is or where the nerve or where the artery is. Yes, they know in theory. Yes, they did anatomy. Yes, you can do cadaver labs. But I think there's a little interesting component to that where if you understand how to do it open, MIS to me seems a lot easier. What are your thoughts on that?
So funny that you bring this up because I have this conversation with a good friend of mine all the time. And he's a big open proponent and wants me to not do as much MIS so that we can do more open things with the residents. And I think that to some extent that's very true. There's only so much that you're going to learn from a cadaver lab. Our kids are really spoiled. They get a cadaver lab like once a week. But even with that kind of exposure, which is not the norm across the country, I think that it is a difficult sort of thing to ensure. But, I think that we're at a unique juncture where there are still so many people who are doing open procedures versus those of us who are not, that you have to kind of count that they're going to get some of that with those providers. It's tough because when you see and kind of commit to that sort of approach to things and that's what you feel passionate about because your patients are doing better and their outcomes are better and they're not taking narcotics and they're moving faster, cosmesis is better. To some point, again, initially your responsibility is to the patient as well as the education. But, I heard your talk with Tyler, and I don't disagree with what he said is, like eventually everything has moved there, right? So, it's the same thing with general surgery residents learning how to do, everything, percutaneously and, endoscopically versus our kids. And they're still going to learn those things. It really just becomes, are they learning it in relation to what's open or are they learning it in relation to what is so critical? Because there's so many things MIS that are critical points, even the pitch of the burr and understanding what to listen for and look for under fluoro and the shots to take. Those are hugely different, but yet still equally critical points to doing a procedure correctly.
Yeah, I agree. There are a lot of finite details that you don't really understand until you physically put the burr in your hand and listen and feel and understand what's happening. Do you have any tips for any younger people who are listening who haven't tackled any cases via MIS but would be open to it? Do you have any thoughts on, well, obviously, maybe we can start in the cadaver lab and get a feel for it, which is similar but not quite the same in my mind. Just like when you do a dissection and you do a perfect dissection. Hey, look, there's no bleeding. Yeah, of course there's no bleeding.
Yeah.
Try it on a real person and see what happens, or an alive person, I should say. But any tips for people who are thinking of starting MIS?
Yeah, I mean, I think it's really get to any lab and any course that you can. Read a lot because there's a lot of really great literature that's coming out these days and just a lot of really great people who are working together. You know, the international community for this has been such a fun thing to be a part of and to see what's coming out of all that. But also, you know, there's the LER Expo courses that are free to students and residents, and it's free CME, and you get some really incredible people just kind of going back and forth. And, you know, I mean, you got Peter Lamb at 3:00 in the morning in Australia talking to you about, you know, I presented like a Charcot case, and he's like, guys, what a tough case. Like, I'm so glad we hardly have diabetes in Australia. And I was just like, what a unique perspective. But those
Yeah.
kinds of things. I have a friend up in New York, Megan Kelly. She works with I believe the Columbia residents, but she does a thing called Beer, Burrs, and Birds. So she does like a journal club at a brewery, and then they use the burrs to sort of do little osteotomies and those kinds of things. So, and they eat chicken wings. That's where the birds part comes in. But
Gotcha.
I think
I was wondering, are they doing it on
Yeah.
birds? They find
No.
pigeons and
that's where they get the wings from. No, but yeah, I mean, I think it's really just handling the burr, you know, I mean, even on sawbones, I think there's a lot to be said with that. You're right. I mean, the cadaveric labs are great, but they're not giving the same feedback as the cases are. But if they can go visit somebody, again, I think you learn so much by watching someone who's efficient, what they're looking for, the shots that they're taking, those kinds of things. But I think the burr handling in and of itself, just holding it. And I mean, it's the same thing as when you first picked up a blade. You know, remember some of the ridiculous ways you'd stand and hold things that you see students and residents still
Yeah.
do,
yes.
and learning to break yourself of those habits. But even like, where do you put the C arm? Like, where do you, what is your ear gate? Like so, you know, I think getting in to labs, cadaver labs, courses, listening to lectures. And then if you're fortunate where you can go sit in with someone, that would be great too.
Yeah, I think that's an important part of that is fluoro, because you don't necessarily want to utilize that burr. Yes, the burr is designed to not do, or let's just say to minimize soft tissue damage. Does that mean it doesn't cause any soft tissue damage? No, you can still cause soft tissue damage, especially with the heat generated, but also just with the rotation nature of it. And so utilizing fluoro and understanding where you are, certain angles are going to lie to you more than other angles in terms of guiding your burr placement. There's been certain times where I'm in there and I'm going along, and then I check a picture. I'm like, oh, okay, I gotta go back this way. That's not, but you may not even know. You may not get that tactile feedback to understand, okay, I moved from resecting the atavistic medial cuneiform, and I started bumping up against the cortex of the medial second metatarsal, and I didn't necessarily get like this dink like that hit me back like a pinball. That thing just gonna go. It's designed to make osteotomies. Like, whoo, you keep going, it'll cut right through the second metatarsal. So, and your angle of the fluoroscopy needs to tell you exactly where you are, because you can't uncut something. Now, is it the end of the world? No, probably not. But you need to understand where you are, because also it's a very difficult skill, I find, to put your burr in a position and not have the burr handpiece and your hand block your view. Because you put your burr down like this and you take an AP, you're not going to see anything. You need to take more of an offset view to be able to understand where you are. So a lot of that comes with practice and, you know, cadaver labs or sawbones or something like that, and watching people who are good at it understand it. It's not as easy as just saying like, oh, well, I can just stick this in there and then do that. And then that's just like we're doing an open procedure. It's not exactly, you know, making that one little leap. There are little technical details I think are important.
Agreed.
So you want to jump into some cases and talk about Cavus foot?
Let's do it.
All right.
We'll be right back after this. For more information, go to podiatrygrowth.com/podpatrol.
So the people have signed up for the 5 email course and 30-minute free conversation with you to analyze where their marketing needs improvement. What steps can they take next?
Yeah, the next step is a deep dive. It's what I call an online practice x-ray. I look into your Google Analytics, your Google Ads. And then the last part of the online practice x-ray is to provide you high ROI marketing plans. A really in-depth diagnostic that will give you a clear direction about what those next steps are to help you grow your practice. This is something I generally charge $2,000 for, but since they're Pod Patrol listeners, we're going to chop that in half and charge $1,000 for this diagnostic. You'll have a written document at the end with the competitor analysis, what you're doing now, and a clear marketing plan to make sure that you can be cost effective when it comes to marketing your practice.
Absolutely. I love to hear that. Paw Patrol listeners are getting 50% off from Jim McDaniel, marketing expert at podiatricgrowth.com. If anyone's interested in more information, they can go to podiatricgrowth.com/Pod Patrol. All right. You want to go ahead and talk through this? It says single incisional approach to the coal osteotomy.
Yeah. So I saw a ton of flat feet, pes planus deformity, when I was in Philly, not as much Cavus. So this is a technique that I learned from Rich Journer, who's a good friend of mine and very much a mentor. And the coal osteotomy, I think when you see it in a diagram in a textbook, it makes a lot of sense. And then trying to figure out how to do that through 2 incisions is very intimidating. And so this is a single incision approach, and you were 100% looking kind of right down at the bundle when you're doing it, but you also get an incredible view of the midfoot and really helps to kind of attack a lot of those complex cavus deformities. So initially, you're just kind of looking at that incision. You'll see the EDB that in this picture you can see we've kind of cut and tagged and are pulling out of the way. A little bit more of a blurry version of that on the right hand side there. So, but yeah, essentially you're going to sort of pull and drag the bundle medially under the retraction and retract away, and then retract your EDB distally and then pull the structure. So you should be able to see like the entire surface of the navicular cuneiform interface and a little bit of the cuboid.
Mm-hmm.
Here, I think we're kind of making the initial osteotomy. So it really is this wedge-shaped cut where you're taking some from the navicula and some obviously from the cuneiform side, and really trying to sort of come to an apex to create that dorsiflexion of that in one fell swoop. I'm typically standing at the head of the bed when I do this, and then I don't wedge out the cuneiform, or excuse me, the cuboid. That really is an osteotomy through so that it can elevate with the rest. If you really cut a good chunk out of that, you're going to drop the fifth met down into plantar flexion, which can be a bear to deal with later.
So what are you aiming for? Like, how big of a wedge are you aiming to take? Are you taking a smaller wedge and then feathering it later? Or what is your aim with your initial cuts?
Yeah, so initially I'm trying to get all of the cartilage off, obviously, but to do that in sort of a truncated fashion. So I'm coming down to an apex. And I think that initial component, the cut off the navicula, is a pretty straightforward one. But then taking not too much of the navicula, if you're going to take a little bit more, I'd say do that on the cuneiform side. And really sort of trying to have those meet. It is a much smaller wedge than you think it needs to be, and you can certainly overcorrect through this. So you have to be careful.
So making a smaller wedge first and then taking
Mhm.
more if you need to.
Yep.
Obviously, you can take more. You can't put it back.
Right, and really kind of just like an Aiken, you're just kind of feathering down and sort of fine tuning some of that dorsiflexion as you move up. The great part about this incision too, and you can see what a small wedge that is. I mean, it's still a wedge. I'm just doing my little air quotes here because it's a little smaller than you think. But this patient didn't need a posterior tibial tendon transfer, but so many of these patients do. And some of the x-rays you'll see, you can really plug the posterior tib in through this same incision. So this was a young patient of mine, a lot kind of going on from an endocrine standpoint, had a really bad overcorrected cavus foot on his contralateral side. And so came to me, and I was really, really scared to do his right foot. You can just see that all of that rotation and the stacking of the metatarsals, pretty big cavus deformity there. And so he kind of needed the works. And so we ended up doing a MIS calcaneal osteotomy, so Dwyer type, if you will, and then posterior tib transfer, as well as a Cole, a DFWO, a Jones with an HIP fusion, and then some of his toes as well, which I think is on the next slide.
Do you remember what he had done on the other side that he didn't, or he was hesitant to have done on this side? Do you remember what procedures were? Are they similar?
Yeah, it's funny because I just saw him today, and we're now going back to correct the left side, which is a much more challenging deformity now. But yeah, I think he had not exactly similar stuff, but some wedge type things where now he is in incredible amount of valgus and just really, bowstringing of every tendon, peroneals, the Achilles. Yeah, so tough case here. So
That is tough.
yeah. So
So
you can just see some of those angles there.
So obviously anyone who's only listening, there's a significant cavus foot deformity, dorsal subluxation of the lesser digits, that classic bullet hole sign, the posterior rotation of the fibula, and what I teach the students is the double density sign of the talus. If you can see the near surface of the talar shoulder and the far talar shoulder at the same time, it means it's not a very good lateral, or they have a significant cavus foot deformity or other deformity. Doesn't have to be cavus, but they have some sort of deformity in there because there's rotation of the hind foot. And so I think sometimes people just think of cavus foot as a pure sagittal plane deformity. Oh, they have a high arch. Well, yeah, sure. But that's not the only part of this. And that's why we utilize calcaneal osteotomies. If you reverse it and you have a flat foot and you do an Evans, that's a triplanar correction, and the reverse is true with a Dwyer. So I think that's an important thing for the younger people listening, is to understand this is not a purely sagittal plane deformity. You can see there's a transverse plane deformity on the AP there, obviously some lateral column overloading, and the talus is pointing off into right field. So there's a lot to understand here when you look at this X-ray. So how do you decide? Let's say you get this X-ray, which obviously you did. How do you decide which procedures to do? Are you deciding that intraoperatively as you go? Okay, we did this. Okay, it still needs a little more. Let's do this. Okay, it still needs a little more. Let's do this. Or are you planning ahead of time? Nope, I can tell we're going to do this, 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 and this.
I think for this one, something so severe, I knew exactly what I wanted to do. I think with something like the Cole, you're either going in knowing that you're doing that and then kind of fine tuning around it. I find that most of these patients need a calcaneal osteotomy. At least the one thing that I think that you can overdo it with is sometimes adding a posterior tib transfer if they don't need it, and really differentiating between that person who does have maybe a more purely sagittal plane issue. But certainly your physical exam, and we know so many of these patients do have a neurological component, so that needs to be assessed and ruled out. And then, also their clinical exam, which muscles are firing, particularly if you're considering a posterior tib transfer or split AT or whatever your kind of method is. Making sure that's a functioning muscle, because we know that that's going to lose a sort of grade of strength as we move it over, and understanding if that's a good idea for a patient. But I think also talking to patients and seeing what their goals are. I had a gentleman with a significant cavus foot, and he was a ballroom dancer. And so when I transferred his posterior tib, he was happy with the position that he was in, but he lost his ability to really invert, and he was really not happy with that. And so, I think understanding what a patient's goals are and being able to relate to them what you're going to gain, but also what you're going to lose, is something that is very important. Some patients that can't get into a shoe could care less, but that's not your decision to sort of make. You have to kind of inform them of what these procedures will ultimately result in, other than we're just going to lower your arch, because certainly that is a component of it, but you don't get something for nothing for some of this stuff.
Yeah, I think you bring up a great point there with the neurological component and working them up from that standpoint. So let's say someone did have CMT or some sort of similar progressive neurological dysfunction. does that change your treatment algorithm and procedure selection? And if so, how?
Yeah, absolutely. I typically, if there is a known neurologic component, certainly having a conversation with their neurologist is sometimes very helpful, just with other things that are kind of contributing and things that they're seeing that we're maybe not. It's definitely stopped me from transferring a tendon or two, particularly in older patients, but also understanding if it's a progressive deformity or not. If you do sort of procedures that are intended to maintain as much flexibility of a hind foot as you possibly can, you're sometimes setting that patient up for failure.
So does that mean, can I infer then that you're
Please.
moving more towards a fusion or a hindfoot
Correct. Yeah.
fusion, a triple, or even maybe a TTC or something in the fusion realm versus osteotomies? Just trying to
Yeah.
translate that for the younger
Yeah.
people.
Sorry.
No,
Yes,
you're good.
exactly.
Okay, so obviously if we have a progressive deformity, then things can progress and get worse with time. So if we're doing osteotomies, yeah, it might look good on the table today, it might look good in the office next week. But if it's a progressive deformity, we're going to be better off in the long run considering fusions to stabilize so that it cannot progress. That doesn't mean it can't worsen. That doesn't mean that things can't change, especially you're not going to fuse every joint in the foot. So things can change, but it may change your treatment algorithm on the front end. So working them up from a neurological standpoint is important. Anything on this x-ray that really catches your eye? To me, it's the digits. I look at the hind foot and I'm like, okay, yeah, I can do that. I can do this. What do you think about when you see the dorsally sublux digits? Do you think those will passively correct with correction of the foot and especially taking a wedge out, which will effectively shorten it a little bit? Or are you thinking you're going to have to go in and tackle the toes each separately?
Yeah, I mean, I think historically for me, I've found that it doesn't. The most I think that you can really accomplish with that, so many of these patients have this underlying adductus that you can see here as well. So some of the way that you're closing down that wedge and tweaking that, you can accommodate for that and make that a little bit better. But for what I've seen in my patients, there's typically something that has to be done, whether that's tendon transfers. I mean, now I tend to do a lot of this stuff minimally invasive, which is a huge time saver. And especially, the Cole is not a minimally invasive approach. And so, or at least the way that I do it, I think that you really have to kind of decide whether it's worth doing all at the same time if you're going to tackle that from an open perspective.
So if you were, let's ignore the hind foot for a minute, because I think we can dissect this case. It's a very interesting case. There's a lot going on here. Let's ignore the hind foot and say their chief complaint was just digital deformities. You said you tackle that via MIS approach. What are your thought processes when you're doing that? Are you doing metatarsal osteotomies? Are you doing something in the phalanx, or what are you doing?
Yeah, I mean, again, it kind of depends on, the flexibility of the toes. This patient did not have a neurologic component, and also still quite young. So, and also having had previous foot surgery that was kind of overdone. So that was a huge conversation with
Sure.
the patient. But for this particular situation, I mean, I do think you've got to figure out how to get the metatarsal phalangeal joint down, and typically that's done with a DMMO of some type. But certainly, if you're not addressing the hind foot and you're not going to account for the adductus, how are you going to go about that? I mean, certainly you can do a proximal metatarsal osteotomy. You could do that open. You could do a Lapierre. You could also do a DOMMO, so a distal oblique metatarsal osteotomy, where you're trying to account for some of that in order to both shorten and allow for sort of plantar flexion of that dorsal dislocation. And then what is going on at each sort of individual level, which I think is really where minimally invasive surgery differentiates itself in digital deformity is you really can have this sort of a la carte approach to each individual toe without filleting open 5 toes after you put in a solid 2 hours of work on everything else.
I hate toes, so I just tell my
Same.
patients we have to cut them off. We're not going to be able to save the toes. We're just going to have to let those go and move on.
How does that work for you? Do they come back?
No, I scare them
No.
away. And someone else
Yeah.
has to deal with the toe deformities.
There you go.
He wanted to cut my toes off.
Mm-hmm.
All right. So what do we got here? This is your post correction, these
Mm-hmm.
post films.
Yep. Yep. He's, I believe, 7 months out here. So we did a Dwyer, but from a minimally invasive approach. So when I do that, I will do my initial cut with like a 3x30 burr. And then I typically am going to the, making or percutaneous incision laterally and going to the medial cortex, kind of bounce off of that and get my initial osteotomy and then start wedging it out. Could also use just a larger base sort of wedge burr to also take a more lateral sort of wedge and then kind of closing it down here. And then we did the coal, which you can see the two crossing screws there. Chamfered head works really great here. So your minimally invasive screws, even though this is not a minimally invasive approach, they sit so nicely on the midfoot, which no matter how big most patients are, they don't have a whole lot of soft tissue here. So certainly be cognizant of that in your hardware selection. And then I typically do find most people can tell you a horror story about an NC fusion. So I usually will add a little something special or extra rather at the medial cuneiform, whether that's a plate or a staple. We did a DFWO here, so you see the secondary staple there, and then a Jones. And I believe we just did capsular releases of his toes. I don't quite recall, honestly. I think that's all it looks like. Maybe some osteotomies there, but you can see certainly the metatarsus adductus is not perfect there, but we accomplished a lot just with the way that we closed our coal down.
Yeah, it
And
looks
also
great.
the posterior tib transfer helped with that too. Really takes the forefoot bears out.
Yeah, it looks great. And, he obviously didn't overcorrect. I'm sure he was nervous having gone through that on the other foot.
Mm-hmm.
And so I have to be a little bit careful. But this is great. I used to hate staples. I thought they were terrible. I thought they were dumb.
Same.
Thought they used to break all the time. And now I love staples. So
Mm-hmm.
I don't know if it's me just getting kind of, impatient in my old age. Like, okay, it's done. Moving on, or if they've really improved the quality of the staple. I think it's both. But
Yeah,
yeah, I
me
used
too.
to hate staples, and now I really like staples.
I'm with you. Yeah, sometimes getting, especially in such small spaces, getting a small plate and then figuring out and the screws and those kinds of things. I agree. The expediency of this is sometimes very nice.
And I like what you did there, where you can fit the leg of the staple between the screws, where it would have to be it may be very difficult to put the plate on and to get that hole for that screw in that exact position and line it up and slide it and then drill it. Oh, that's not right. Okay, well, now I have a hole and I need to make a hole next to a hole. That's very difficult. So if
Hmm.
you're going to try, if you already have screws in there, which I do that a lot for my TN fusion, I do a screw and a staple.
Yep.
If you already, and sometimes two screws and a staple, but if you already have screws in there, it's going to be difficult to put a plate on it. So I like your technique there, and you could kind of slide those staples in there and kind of fit in there a little bit better than another screw as part of a plate construct would be.
Yeah, I'm a big believer in the nitinol technology too. I love the idea that something is continuing to work and compress, as the bone sort of resorbs and kind of keeps that going. I think especially at joints that make me nervous a little bit. So TN and NC for sure.
Mm-hmm. Yeah, I'm not smart enough to remember the actual papers, but obviously we know that compression screws start to lose their compression within the like 3 hours or something of putting the
Hmm.
screw in there. So having something that does maintain some continuous compression, especially across those, like you said, TNNC joints that are ripe for non-union and having complications is very helpful for us. So yeah, significant improvement in the Meary's angle and all that.
Yeah. Yeah, so similar patient, not quite as much adductus, but similar radiographic findings, significant increase in calcaneal inclination. So that stacking of the metatarsals that you see, just that sort of increased Muries, where your talus is sitting almost flat in the ankle joint compared to the first metatarsal. So I think our recipe was relatively similar here. Sort of, I believe yeah, still MIS on this calc osteotomy, but
Mhm.
I did use staples and all this, and this guy did not need any real digital work there. So, but you can see again where that posterior tib kind of anchors in nicely into the cuneiform. That's that kind of little opening that you see in between the screws there. Yeah, I think sometimes that's also a planning point is getting that thing down. The cuboid obviously has a lot of real estate, but you're going to need a lot more tendon, I've found, to get it to go that far. So really kind of planning your hardware placement and where the tendon is going to go, I think is critical. And I typically will harvest the tendon, and I tend to do that wet. I do my calcaneal work wet if I'm doing that minimally invasive. And then I kind of tuck the tendon away, and that's the last thing that I'm doing is anchoring that tendon in, just so that
Sure.
we're not pulling and tugging on that. Even if we're doing digital work and those kinds of things, I just don't want to mess with that a whole lot once it's docked in.
Is it a biotenodesis anchor? What are you using for your fixation of tendon?
Yeah, biotenodesis, and sometimes I will still use like a little button, a little sterile button on the end. But I've gotten more where I'm also now almost like if you're setting up a tent, you have that plumb line off to the side. I'll run like a separate sort of all suture anchor off and sort of anchor it down just to sort of prevent some of that bony resorption and loosening around the tendon. Because you can certainly see that where you're going, man, I thought I had that a little tighter, just like an Achilles. I've never had one that I've felt like I've made too tight, knock on wood. I think the converse can be true.
When you do your Dwyer, are you sometimes intending to do a calc slide with it?
Mhm.
Because sometimes you can use that and then facilitate even a little bit of extra correction.
Yeah.
Or what are your thoughts on combining a calc slide with a Dwyer versus just the Dwyer?
I think it's a great idea. And particularly I find it difficult to, especially minimally invasive, just slide that laterally, to sort of correct for that. So I think having that sort of loss of cubital content, if you will, to just sort of be able to close that down and be able to mobilize some of that periosteum really helps. I think you can also slide that tuber dorsally to decrease some of the inclination, which can really
Sure.
help. So
Yeah.
I think it's most of the time I find that I'm kind of green sticking that or kind of, fenestrating that to sort of make that crack a little bit intentionally for sure. Similar case, I think these are kind of just all different versions of the same thing, but
Yeah.
again, a little bit more similar to the first case. This is an older gentleman and just significant cavus he'd had. You can see the sort of repetitive stress fractures on the fifth metatarsal. I think
Yeah.
at one point it even just had this like really thick callus and like superficial wound there, non-neuropathic, non-diabetic, really active guy, surprisingly. And so he definitely needed a lot more work with the digits. But again, similar radiographic findings. You see that bullet hole sinus tarsi, stacking of the metatarsals, the relationship of the first metatarsal to the talus, and all that good stuff, and just the rotation there. This one I got a little too cute with the wedge. I think I was using a screw here on the DFWO and needed a plate to sort of facilitate that, but it worked just fine. And then here we did 3 screws for the cold. This one you can actually see the anchor where we were sort of intermediate cuneiform with the PT transfer, and then I drug that little plumb line off with another anchor off to the side there. And then I did do digital fusions, prepping really the PIPJ there. Sorry, I cut the tips off. Not in real life, it's just the x-ray.
That's a Dikis
But
procedure.
yeah.
Cut the
That's
toes
right.
off.
The Dikis, we gave him the Dikis. So,
It
and then
doesn't
I
sound
think
very good.
it doesn't.
No,
Once I said it,
that
I
doesn't
wanted
sound
it
good.
back. Yeah.
Yeah.
So yeah, so I don't think he had a Jones Tino suspension as well. So, and then but he had bilateral deformity, so we eventually kind of went back. It's funny about this guy is, I really was super happy with it. He still had, and I think it's so important to evaluate these patients for lateral ankle instability because he still had a lot of play. We did end up going back sometime after we did his right side and ended up doing a lateral ankle stab. So I think that's definitely something I've learned is, even if that's not something that they're complaining of, you're only going to stabilize so much, particularly in an older patient with a sort of long-standing chronic deformity, is really evaluating that and having that on your recipe if that's something that you're finding you still see intraoperatively.
Yeah, I think that's a good point because obviously chronically with the cavus foot deformity and the stretching of the lateral side, obviously those
Mhm.
ligaments are going to stretch with time. And then all of a sudden over the course of a few hours, you took this thing that's been sitting there for years and years and years and put it in a completely different position. And you could picture how those ligaments are then going to be lax because you just took all the slack out of it because you changed the entire position of the hind foot. So
Mhm.
I think that's an important point you made there.
Yeah. Yeah.
Those are really good cases.
Thanks.
Cavus foot deformity can be very intimidating and very challenging, especially if there's neurological component to all of that stuff.
Sure.
It could be very tricky. So thanks for sharing those. Those are great
Yeah.
cases.
Yeah. Thank you.
Yeah, absolutely. So thank you for hopping on tonight. I appreciate
Yeah.
your time. If students are interested in checking out Inova as a program, obviously they can go through their normal channels. But
Mhm.
is there anything that you'd like to mention to any students that are interested in coming out?
Yeah, they're always welcome to visit, and we encourage it. We have a great residency coordinator who they can contact by the name of Marina Crawford. She can get them all set up. They have to have all the same stuff that they're going to need for residency, so their immunizations and all that kind of stuff. We're pretty careful with tracking all that, but it's really just going through the right channels, reaching out to some of the residents that are there, sort of seeing what the program's about. Everybody has their own webpage these days and videos and those kinds of things, so just familiarizing themselves with the campus and reaching out if they can visit and those kinds of things. But yeah, we're always open to that and always have students through with the externships and those kinds of things, but also encourage students that are not rotating with us to come visit as well. So
Absolutely. You guys have a great program there. So
yeah,
congratulations
thank
for
you.
that and keep up the good work.
Thank you so much. And thanks for having me. I really appreciate it. It's been fun to kind of share these little interactions and it's such a fun, weird little community we've all had in some of these online platforms. So thank you.
Absolutely. Thank you so much for hopping on tonight.
Yeah,
Thank you
you
guys
got
for
it.
joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.
Paw Patrol. Paw Patrol. Paw Patrol.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.